Welcome to another episode of the Dendrite Podcast with Said. This is a conversation with Dr. Harold Atkins, Associate Professor at the Department of Cellular and Molecular Medicine with the University of Ottawa, scientist in the Cancer Therapeutics Program at the Ottawa Hospital Research Institute, and attending physician in the Blood and Marrow Transplant Program at the Ottawa Hospital. During his career, Dr. Atkins has focused on the clinical and regenerative applications of hematopoietic stem cell transplantation, or HSCT for short. His research explores HSCT for severe refractory autoimmune diseases, stem cell transplantation to promote immune tolerance in organ transplantation, and cancer virotherapy using virus-infected leukemia cell vaccines as personalized immunotherapy. His work bridges clinical hematology, regenerative medicine, and cancer immunotherapy. We hope you enjoyed this episode, and here is Dr. Harold Atkins.
Good morning, Dr. Atkins. Thank you very much for accepting the invitation.
Thank you. It's a pleasure to be here and look forward to talking about life in medicine and research and whatever.
So, how about we start by a bit about your background, about your journey. What happened that you became who you are? The question.
Depends how far back you want me to start.
As long as you'd go.
So, growing up, it was probably in high school when I was taking biology, like Biology 101, and they asked us to do the health project, right? Everybody does the health project at one point in time. And I did a project on how the immune system worked. We didn't know very much at that point in time, but I thought it was really cool. And I thought, oh, wow, it'd be great to be a doctor and figure out, how things work and be able to fix things if they weren't working. And so that really set me on the career path. And then I got into University of Ottawa undergraduate science and thought, oh, science is really cool too. And like figuring out how things work in biochemistry at that time. And so my goal in coming through medicine was to have a career as a clinician scientist for what it was worth. And so I did get into medical school here at the University of Ottawa and went through and really liked the science, but all the foundational sciences of medicine. But I also liked patients, taking care of patients and seeing how you could apply things from your understanding to help patients get better and vice versa, how your understanding of patients helped your understanding of diseases. And I had some really, really top-notch mentors as I was training here at the university. And so that really set me on my career path. I wanted to become a hematologist and stem cell transplant doctor because I thought that was the coolest interaction of the lab and the patient. And that was in part of because of an elective where I was able to, was taught how to do bone marrow aspirations, and I could take the bone marrow aspirate to the lab and grow individual colonies in tissue culture from that bone marrow. And that explained how blood grows, hematopoiesis. And so from there, I did an internship because I liked, at that time you could do a rotating internship. It was where you could do a little bit of everything again because everything is interesting and it's good to know a little bit about all fields of medicine. And then I came back here and did internal medicine training. And again, it reaffirmed my desire to be a hematologist. And so through applying and help from my mentors, I was able to go to Seattle and do a hematology and transplant fellowship there.
So it appears that from the very beginning you had this vision with immunology and then medicine and then to both, and then it just gets higher and higher in terms of resolution. Could you unpack hematology or hematopoietic stem cells and bone marrow? So you touched upon that a bit, but what are the applications? What's the scope that we're looking at in terms of both the clinical side and both the science side. I mean, they're huge. So
Yeah. So hematology is a big field. It has, it deals with all the diseases of the blood, but also many other diseases because
blood goes everywhere.
Blood goes everywhere, and other diseases perturb the blood. So the blood gives you clues on diagnostic testing and whatever. But I really liked the technical aspects of transplant because it's kind of still even cutting edge. You use the strongest kind of chemotherapy or radiation that you can, and you put in stem cells, and you can understand their biology and watch how they fix certain things. And for a long time, that was mainly to treat cancers, where you use the high dose of chemotherapy radiation to kill the cancer. As a side effect, you kill the bone marrow, so you have to do the bone marrow transplant. And one of the limitations has been if there's no tissue match, or the tissue match is poor, you get a disease of the immune system called graft versus host disease, where the donor's immune system attacks the recipient. And so there's technical aspects of that. There's understanding the immunology, and so that's all was very cool to learn about and to work in practice. To be a pragmatic immunologist, so to speak. And then, but you move on because you learn what the stem cells can do, and you start looking at, maybe there are other diseases where there's a disease in the stem cell, and you now have tools to get rid of it, or diseases in the immune system where you can have tools to get rid of it. And so that ultimately has kind of was a side project, but ultimately has become my main clinical practice, where we now do transplants for a variety of severe autoimmune diseases. But then gene therapy technology is coming about, and we have patients with a number of genetic diseases of the blood, sickle cell disease, thalassemia, a whole bunch of inherited diseases, of storage diseases, and
storage diseases. What?
Where there's enzymes that degrade toxins are missing, and so the toxins build up, and they cause neurologic or bone disease, or any number of things that make children unwell. And yet we're unlocking the ways to fix it. And so one of my desires when I went away to train in hematology was to become a gene therapy doctor.
Really combine all the front lines of all of them together.
Like when I trained, that was just really a pipe dream. And it's really taken until maybe 2 years ago where I was able to do gene therapy.
Actually doing gene therapy.
On of a patient with sickle cell disease in a clinical trial, where the collective community understand how hemoglobin is regulated, how the different forms come about at different ages of an individual, what the regulating factors are, how to alter the genetics of the regulating factors so as to increase the type of hemoglobin that you want and get rid of the hemoglobin you don't want, and then be able to do that in real live autologous stem cells enough to do a stem cell transplant and use those for a stem cell transplant to fix sickle cell disease. And
it's just fascinating how we can just take a look at the history of sickle cell anemia, just look at the disease, and as the field like figure out what the hemoglobin looks like, and then the proteins, like what's the underlying factor, it's a century-old history, and it's still moving.
Yes, it's almost a century since sickle cell was discovered to be the first. It was the first disease that was understood to be have a genetic basis. Fellow won a Nobel Prize for that, of course. You know, our understanding of hematopoiesis, how blood cells grow, but how stem cells are the basis of that. That was a Canadian discovery in the 60s. How that had to be, you know, the practical parts of doing stem cell transplants, understanding. First, we had to understand the immune system enough to do allo transplants. Again, someone won a Nobel Prize for that. But then we needed to learn cryopreservation techniques and manipulation techniques and how to culture these cells. There was a whole bunch of very prominent scientists that won awards for sorting that out. And then finally, CRISPR technology to be able to do the gene engineering. And people won Nobel Prizes for that. And so this whole confluence of different things had to come to pass before we could actually test this idea in humans. And you know, it's again, a remarkably powerful technology that's kind of just on the cutting edge of being able to do it. But it's like having penicillin for the first time. You don't need to do 1,000 patient randomized trial to know that it works, and that there are profound,
it works.
Profound improvements in a patient's medical condition, quality of life, I think there will ultimately be a survival benefit.
So let's talk a bit more about the therapy. So the combination of gene therapy and stem cell transplantation. That's what I understood is the way to go, or is one way to think about sickle cell in particular, and of course many other diseases. So as you mentioned, there comes a lot of different complications and difficulties that are technical, like does it work, does it not work? But what are the main challenges or main things to just take care of while you're thinking about this combination? And also, how does it develop in terms of when the stem cell, for example, is now transplanted, but how does it develop to finally maybe overcome the genetic lacking that the patient already has?
Yeah, so when we treat or perform a stem cell transplant, we first identify a source of stem cells. And so sometimes that's the patient's own, sometimes it's a related donor, sometimes it's an unrelated donor. The technology has improved to the point where we used to only be able to accept a full tissue match between the donor and recipient. Now we can do a half match between the donor and recipient, so that
opens up the options of...
Right. So now really anybody who has a parent or a child would have a potential donor. But, you know, in the future, we may be able to engineer these cells to remove some of the immunologic differences that lead to rejection or graft versus host disease. People are working on that. Whether that's a practical thing or not quite clear. Once we identify the source of the stem cells, well, we can collect them, or we can freeze them, or you know, when we collect them, they're not a purified group of cells. So they're a mixture of blood cells and immune cells, and so we can separate them if we want to, and keep ones that we want, get rid of ones we don't want, or we can give the whole mixture, because sometimes the cells that you carry along with your stem cells have biologic properties that are important for the care of patients. Once we've then the patient is is treated, and treatment depends on the disease. So we might use high doses of chemo or radiation or antibodies to kill a cancer. We need to use some degree of treatment to get rid of the stem cells that are there, because we want our new ones to take.
To have space to grow.
Yeah. And then as well, we want to, if we're doing a donor transplant, we want to get rid of the recipient's immune system so they don't reject the graft. Just like a kidney transplant recipient would be on immune suppression to prevent rejection of the kidney. So we would want to do that. So depending on which of those goals is most important, we have different recipes that we use to treat the patient. Then we put the stem cells into the patient, and then it comes the real bit of business in this field, is to treat the patient through all the side effects of the drugs that we use. And that requires a big multidisciplinary team. It's not just one doctor, it's a group of doctors. We have a whole host of nurses with different roles, dietitian, physiotherapist, pharmacist, and we all work together to mitigate and minimize the effects of the treatment on the patient, so as to open up the therapeutic window.
So now I'm trying to think about, so the transplantation, the immune system is a huge aspect of it. And you mentioned that there are, genetic engineering on the donations that could perhaps remove some or alter some of the non-self elements, so we can increase the host. But now I'm thinking about long-term, because I think about other, particularly organ transplantation, that's, after a few years, it has to be changed because the immune system is basically is done with it.
Well, again, these are some of the, you fix one problem and then you have new problems that you have to face. So an organ transplant, they're life-saving, right? You take a patient who doesn't have a functioning liver or doesn't have a functioning kidney, and you can transplant them and you save their life because they have organ function. But you have to suppress their immune system, and that leads to a whole host of problems, some related to having an impaired immune system and risks of infection, but others metabolic side effects of the drug, others immunologic side effects like loss of cancer surveillance, so an increased risk of secondary cancers. So now that's what the fields are working on. How can we do this better? How can we find new, more focused ways of suppressing the immune system so they don't reject the graft, but they
keep doing what they're supposed to do, looking for other cancers and just being the barrier against any sort of disease coming.
And so and I don't have the answer for that, and I think the field is still working through lots of different options. Let me give you an analogy though. So when we do a donor transplant, the donor immune system can react against the patient. We call that graft versus host disease. We have ways of suppressing or preventing it. But we also know the donor immune system attacks the patient's underlying cancer.
Like the Trojan horse, the organ is attacking.
And so it's called graft versus leukemia. And we haven't been able to separate the two, but we know both of those are real things. So so another strategy that has come about are these chimeric antigen receptor T cells. And so again, like graft versus leukemia, you could put in donor immune cells or immune cells into a person and have them target the cancer. And that's what we do with the current CAR T cells. So it's a synthetic molecule. It has a a targeting moiety that attacks a certain protein called CD19 that's expressed on the B cell malignancies, leukemia, lymphoma, and those are very powerful cells. Now, right now, our technology is to take a patient's own immune cells, modify them, and then put them back in. But that's a 3-week process. In those 3 weeks, these diseases are so aggressive that we lose some patients, or they're not well enough to get to the point of treatment. So some people in the field are thinking about off-the-shelf CAR T cells. So they would have a donor who would have, of course, not be matched. So they have to cloak those cells so that they evade the recipient's immune system. So they have ways of suppressing certain histocompatibility molecules on these off-the-shelf molecules. So they do multiple kind of gene engineering of them. And the investigator's goal is, well, we'll have them on the shelf. Someone shows up with leukemia, you take these ones and just ready. Inject them and it's ready. Now, I think there's going to be issues with that because, one, there's a inherent, depending on how you engineer the cells, lentiviruses have an inherent risk of insertional mutagenesis, and there's always the late cancers. But then even worse, you've taken away the immune surveillance of these cells because you've suppressed their immune recognition molecule.
So after it's done its business, they're still hanging around.
Yes.
Under the
yes, with a mutation in them. And if they're replicating,
you don't want that.
so it could be another situation like organ transplants. Well, this is life-saving. You buy people 10 years but we don't know what's going to happen 15, 20, 30 years down the road. So those will be the next set of questions.
So you mentioned viruses. So virotherapy, using viruses to have them play a role in this dance of immune system and cancer and everything is going on. And we've studied like the whole program, like the first semester is just on phage therapy, but that's so we're familiar with that against bacteria and the particularly persistent bacteria, the ones that we can't do anything with them with the whole battery of for example, penicillin and other types of it. But now it's not against bacteria, it's against cancer, or it's playing a role in terms of immune system. So how does that work, or where that is in the...
So I was really lucky when I joined the staff at the Ottawa hospital. I was given an office next to John Bell. and John Bell is a virologist and immunologist by training. And he has this very creative ideas and decided that maybe viruses can help treat cancer because cancers, the process that transforms a cell from normal to cancer breaks down their antiviral defenses. And so in theory, certain viruses can go in and it's kind of the weak link in the cancer cell. And so the virus can take hold and kill the cancer. And so there are trials, there are a couple products related to virus therapy, but there comes a point where maybe we can make them better. And so there's a lot of work in the field on arming these viruses, so putting in payloads that will help kill the cell that gets infected, but maybe also the cancer cells next to the cell that gets infected. There are ways of using the viruses to stimulate the immune system or to kill the vascular tree that's supplying the cancer. So those are all different mechanisms that these viruses may mediate. And then, a whole there's a whole group of people who are working to reduce the toxicity of the viruses. So you want viruses that, attack the cancer, but not attack the normal tissue that's surrounding the cancer. And so over time, there's, as cancer biology gets elucidated, there's ways of again engineering these viruses to work better. And that's, I think, kind of it's quiet right now because everybody wants to do CAR T cells or direct immunotherapy, but I think viruses will have a renaissance in the future too.
Just so fascinating with the option of genetically engineering the cells. Now everything is just a matter of imagination and whether then one can actually make that workable, operational.
Right, and so that's, we're just at the beginning of that, like we've had, I don't know, 100-year history of using small molecules, chemicals, to adjust the function of the body. But we have such a better understanding of how the whole thing works now, from DNA and genes to gene regulation to epigenetics, and we have the tools in the lab to engineer almost anything. Like, it's remarkable the number of organisms that can be genetically engineered, from simple viruses to bacteria to
yeast and everything.
To mammals, right? And it's just, how do we make these tools robust enough to use them in people? And we're just starting to see the light of day on that. Some of them are RNA analogs that we can give that alter the gene function or provide gene function. Others are engineering cells to do different things, like in the hemoglobin to have the red cells, the stem cells produce red cells that produce fetal hemoglobin rather than sickle hemoglobin, so that has profound consequences on the phenotype. And so, but it's all still kind of, how do we use this? What's the best way? What are the pros and cons? But, in your career, these will become more standard ways of treating people. And it's not that we can get rid of small molecules or biologic moieties like monoclonal antibodies, or even there, people are modifying the antibodies from their native form. They're no longer a native antibody. They have two targetings on it, and those two bring cells together that do new things too. And so there's a whole host of new and more sophisticated treatments that I think will come to pass, and using our ability to mix and match different molecules and make things work
one will
better.
Address the shortcoming of the other one, and together.
Yeah.
How difficult is it? Because what you're mentioning is very, very cutting edge, and it's both on the clinical side and both on the scientific side. So how difficult is it to just stay updated while you're also doing practice in like this two different lines? I mean, it's not really two different lines, but there are two different arms of it, as the field is also growing.
Yeah, I mean, it's staying curious, and you have to find the time. In part, the regulatory bodies mandate that you spend some time learning, right? For your licensing credentials, you have to have a certain amount of educational things throughout the year. But they're very open about that, because we've talked a lot about the impact of science on medicine, but there's also advances in the understanding of society and sociology on health, and those are have probably bigger impact. The science is going to treat diseases, but the social determinants of health, little changes make big difference in the population health. And so understanding how all these things work is good, and keep, so not everybody needs to know everything, but you have to work in a community where all these different ideas come to pass.
It's such an interesting thing to look at, for example, from a single cell to a tissue or to a body. All of it, it's an organism, so it's a complex system that's working together. And you could be interested about little details, or you could take a look at the governing regulation of, like, for example, gene regulation, or immune in terms of immune system. Like, it's such a complex system that every it has a lot of emergent phenomena that when things come together, they now have properties that different parts of it doesn't have. Now, it's the same for a society as well.
Yes.
So.
Yes, and all sorts of different fields are important. Economics is important. How are we going to afford some of these? If you're developing a new product, how's it going to fit into the market? Is it a sustainable kind of field? Is there enough people that have that illness that make it worthwhile? Which is not to say that we shouldn't devote attention to rare diseases. Those are important to take care of those members of society, but also, on the other hand, our understanding of how the body works has often come from our learning about how a rare disease comes about. And so, all the issues in medicine are multifactorial, and having people not just be open to these new changes is going to be really important.
And I think it's very, at the same time, difficult, and also very, very satisfying to build this new, because you're working on the intersection of medicine and science, and, as you mentioned, sociology, and you're working with people all the time. So it's moving at the edges, at the borders of all of these come together. And there's a lot of building and rebuilding, I imagine, of a lot of different things.
Yeah. So there are two things. One, communicating is really important. Informal communicating often leads to brainstorming and new ideas. And you're right, it's the advances are going to come from the intersection of fields. And so having buddies who do different things and being able to talk about them is very rewarding, and where you learn a lot. So
where does teaching come into all this?
Well, it's just another part of it, right? And so so teaching seems like a chore at the beginning of your career, where you are at, if you're at a teaching hospital, you have students. Well, as your career goes on and you get more senior, you think, I'm going to have to retire one day. I hope that there are people to take over, but not only take over, but expand the field. And so you become a lot more interested in making sure that there's new students are well taught, and so it's just, again, some people do it because it's rewarding for them. Others do it because it's part of their job description. But when you think back how your teachers were patient with you, and you want to pass that on, pay it forward. So you do it in part because of that.
One thing that's really fascinating to me is the implicit learning. Is that, well, there is a lot of things that we learn by studying from in classroom or just in, but there is also a big portion of other things that is just how to live. And we learn that implicitly through just experience. So you just mentioned that by remembering how your mentors or your professors were patient with you, now you recapitulate that in the way that you would treat your own students and on other ways, like just people that you interact with. And that comes to you when you didn't perhaps know, but now that comes to you when you need it, actually.
Yeah. I mean, so experience is really important, right? And we have these kind of artificial stages in our training, right? We have first year, second year, third year, you become a medical student, then you become a resident, and then you become a specialty resident, and then you become a fellow, and then you become a staff. But it's a continuum, and it's a lot of building knowledge base. So you can't do that all at once. It takes time, but it's also learning the experience of learning how to deal with situations and become better at that. And, how to learn, you learn how to learn, you learn how to take care of yourself in life. You learn how to interact with people. So it's again, it doesn't end when you suddenly got that staff job. Oh, great. It keeps going on. And like I feel that learning is I've been very blessed because I've been in fields where I've been able to learn from people that are the best. I wasn't particularly enamored by neurology or rheumatology when I was a medical student, but now most of my patients have a neurologic disease or a rheumatologic disease. And I've been able to learn from so my colleagues, I've been able to learn from them, and they're not only excellent teachers, but some of the world's best, and so that's a good way to learn, and so don't even when you graduate, you can't be afraid of learning from your colleagues, and it's even worth the opportunity to seek them out and work with them.
You mentioned how you have to also learn how to take care of yourself through all the journey. So how does life outside of the hospital and all the complications, all the life outside of hospital, there's the science, there's the clinical experience, there's the teaching.
It's hard to balance. There's a lot of pressures. There's just a lot of pressures in getting through life, taking care of yourself, taking care of your partner, taking care of children if you have children, if your parents are older, taking care of them, taking care of the house you live in, if it needs repair. It's a lot. And again, I don't have a good answer for how to do that. I think everybody has to find their own way of dealing with it, but you do have to devote enough attention to it that it doesn't fall by the wayside, but also that you can't not pay attention to your training and your career as well, and in part it's not only a career, but it's the way you earn your living, and so it all kind of has to fit in there, and you have to be not afraid to alter it the way it works for you. One of the things is you're sitting at maybe at the start of your career, you don't really have a whole lot of flexibility, and so it's actually harder when you're a student or a resident, because you have to show up somewhere, you have to be there, you have to be on call. You have less flexibility as you grow go through the training, and once you have your own practice, well then it's a lot more flexible. Even if you're in a group and you work with other people, you're kind of more in charge.
You can now create different environments than you're working.
So it gives you a little bit more opportunity to balance that work-life balance.
And perhaps the most interesting or difficult question of all of it: what's the meaning of life? It's the cherry on top of it.
Yeah, that's. I don't think I can answer that.
I think it's a very personal thing too, because as you mentioned for the previous question, it's really how you yourself go through life and you make of it what you make of it. So
yeah.
Thank you very much. It was a absolute pleasure. Thank you very much.
Thank you. All the best with the podcast and with your training, and I hope everybody who listens to this has a fruitful and rewarding career in medicine. It's a great thing. And
thank you.
Good.
Thank you for listening to this conversation with Dr. Harold Atkins. We discussed his journey into hematology and stem cell transplantation, the use of HSCT in severe autoimmune diseases, the potential of stem cell transplantation to promote immune tolerance in organ transplantation, and the development of cancer virotherapy as a personalized approach to treating blood cancer. This is a Done Right podcast. To support it, please share this episode with any one of your friends or anyone else who might be interested. We hope you enjoyed this episode, and see you next time.